Well, welcome back from the break. This is the working group members, and I put my gratitude out to all the members for being so helpful in our deliberations. Today's session is going to be informational, and there will not be any votes taken. There'll be 3 presentations, and those will be meningococcal disease among men who have sex with men, meningococcal disease and vaccine response in HIV-infected persons, and the use of Serogroup B meningococcal vaccines during outbreaks on college campuses. Jessica McNeil will be doing the first 2 talks, and Manisha Patel will be doing the third. In terms of additional activities of the work group, of course, the comprehensive meningococcal statement was published in March of 2013, and the ACIP updated HIB vaccine statement will be published in a few days. Also, a policy note from our previous votes on MenB in infants at increased risk for meningococcal disease is to be published in March. And the work group is involved in early thinking about the approach to the use of meningococcal Serogroup B vaccines. I also should mention that there's been convened a meningococcal outbreak work group. This is an ad hoc work group that has members of, some members of the meningococcal work group, some ACIP members, state public health officials, college health professionals, and CDC members. And the goal of this ad hoc group is to review available data on the recent epidemiology of meningococcal disease and outbreaks and consider options for updating the current meningococcal disease outbreak guidelines. Also to develop guidance for use of meningococcal vaccines, both licensed and unlicensed, in an outbreak setting. So ACIP will likely hear more of the output from this work group. Thank you.
Good morning, everyone. In my first presentation today, I will be discussing meningococcal disease among men who have sex with men, or MSM. Before I begin, I'd like to acknowledge Dawn Weiss from the New York City Department of Health and Mental Hygiene, Lori Mascola and Rachel Sivan from the Los Angeles County Department of Public Health, and the state and local health departments who shared data on MSM cases that will be presented today. I would also like to acknowledge Lara Mizagades and Hashime Kamiya from the Meningitis and Vaccine Preventable Diseases Branch, who led this analysis. Outbreaks of meningococcal disease have been reported in the MSM community. The first outbreak occurred in Toronto in 2001, and subsequent outbreaks have been reported in Chicago and New York City. These outbreaks have all been caused by Serogroup C, sequence type 11, a common invasive strain of Neisseria meningitidis, and a frequent cause of outbreak cases. PFGE patterns have differed in each of the MSM outbreaks, which suggests that different strains have been responsible in each of those outbreaks. The largest and most recent outbreak among MSM occurred in New York City, and it spanned from August 2010 through February 2012. In total, 22 cases and 7 deaths were reported in this outbreak, and the mean age of cases was 34 years, and 55% were HIV-infected. In October 2012, the New York City Department of Health and Mental Hygiene began recommending meningococcal vaccine for all HIV-infected MSM who met certain high-risk criteria. These recommendations were later expanded to include vaccination of all HIV-infected MSM and MSM regardless of HIV status who have regular, close, or intimate contact with men met through an online website, a digital app, or at a bar or party. Meningococcal vaccination of MSM in New York City began in October 2012, and the blue line represents MSM who received at least 1 dose of meningococcal vaccine. Uptake was relatively slow in the target population from October 2012 until March 2013. The final case in the outbreak occurred in mid-February 2013. Increased awareness and press related to the outbreak and vaccination campaign began after the expanded vaccination recommendations in March 2013, which increased uptake over the next several months. During a 5-month period between December 2012 and April 2013, 4 cases of Serogroup C meningococcal disease and 2 deaths were also reported among MSM in Los Angeles County. The mean age of these cases was 31 years, and all were HIV negative. Little is known about the epidemiology of meningococcal disease among MSM, and most states do not routinely collect information on MSM status during their meningococcal case investigations. With the outbreak in New York City and additional cases in LA County, we felt there was a need to better understand the burden of disease and potential risk factors for meningococcal disease in the MSM population. A call for meningococcal cases among MSM was posted on EpiX on May 14, 2013, which asked states to review all of their meningococcal case reports among males 16 years of age or older occurring between January 2012 and May 2013 to determine if MSM status was recorded. Questionnaires were completed for cases that occurred among MSM, which collected demographic, risk factor, clinical, and laboratory information. Cases were classified as either MSM cases residing in New York City, MSM cases residing in Los Angeles County, or MSM sporadic cases, which were all other MSM cases, or men not known to be MSM. The MSM population in each reporting jurisdiction was estimated using 2012 census data for males 18 to 64 years of age and published estimates of the proportion of MSM in the United States, which is 3.9%. All contacted health departments responded to CDC's request for information. 45 health departments reported one or more meningococcal disease case in a male between 18 and 64 years of age from January 2012 to May 2013 for a total of 235 cases. Of these, 33 reported from 10 health departments were identified as occurring among MSM. 17 of the 33 MSM cases resided in New York City, 4 resided in LA County, and an additional 12 cases identified as occurring among MSM were considered sporadic. Serogroup C accounted for all of the New York City and Los Angeles County MSM cases and the majority of MSM sporadic cases. Serogroups B, C, and Y each accounted for approximately 20% of cases occurring among other men, and Serogroup W accounted for 7%. Serogroup information for 34% of the cases was unknown. Among the MSM cases, 5 had a record of travel within 2 weeks prior to disease onset. 7 out of 11 MSM cases who reported current drug use were related to the New York City cluster. The prevalence of smoking among MSM and cases reported among other men was similar, and meningococcal vaccination history for MSM cases was largely missing. HIV prevalence was higher among sporadic MSM cases and MSM cases occurring in New York City when compared to cases occurring among other men. No MSM cases from Los Angeles County were HIV positive. This table shows the estimated annualized rates of meningococcal disease among MSM and other men. For other men, the estimated annualized rates were similar for men living in areas where sporadic cases only were reported and for those living in New York City and LA County. The estimated rate for MSM living in New York City was 11.7 per 100,000, and in LA County was 2.3 per 100,000. The estimated rate for MSM living in areas where only sporadic cases were reported was 0.24 per 100,000. Several considerations regarding the estimated rates of meningococcal disease among MSM should be noted. First, most health departments in the U.S. do not systematically collect information on MSM status during case investigations. While this information is sometimes captured during case interviews, the number of meningococcal cases occurring among MSM may be underestimated. Additionally, MSM population estimates were not available for the majority of query jurisdictions, and a single population and proportion estimate was uniformly applied across all jurisdictions. Therefore, MSM population denominators may be over or underestimated for certain geographic areas. CDC has continued to request passive reporting of meningococcal cases occurring among MSM since May 2013. 10 additional cases have been reported from 7 states during that time. 6 of these cases were Serogroup C, 3 Serogroup B, and 1 was Serogroup Y. None of these states has met the current outbreak definition of more than 3 cases of the same meningococcal serogroup occurring in less than a 3-month period that results in a primary attack rate of more than 10 cases per 100,000 persons. Outbreaks of meningococcal disease do occur among MSM. A small increase in risk was identified among MSM living in areas where only sporadic cases were reported. However, the overall burden of disease is low. In addition, a high proportion of MSM sporadic cases were also HIV infected. The ACIP meningococcal workgroup does not propose recommendations for vaccination of all MSM in the United States at this time. ACIP recommendations for the HIV-infected persons will be discussed in the following presentation. CDC does support state and local health department recommendations for vaccination during identified outbreaks, and continued study is needed to better understand transmission and risk factors in the MSM population. Thank you.
And I think we're going to proceed on to the next presentation before questions.
So in my second presentation today, I will discuss meningococcal disease and vaccine response in HIV-infected persons. And before I begin, I would again like to acknowledge Don Weiss from the New York City Department of Health and Mental Hygiene, as well as the principal investigators and surveillance officers from the Active Bacterial Core Surveillance System, and Henry Wu, formerly of the Meningitis and Vaccine Preventable Diseases Branch, for sharing data from two separate analyses of risk of meningococcal disease in HIV-infected persons that will be presented today. HIV is an established risk factor for several bacterial infections. However, the current incidence of both meningococcal disease and HIV infection in the United States has made evaluating the risk for meningococcal disease in HIV-infected persons challenging. HIV infection is not an indication for routine vaccination in the current ACIP recommendations. However, if an HIV-infected person is vaccinated, the recommendations state that they should receive a 2-dose primary series. Data on the relationship between HIV and meningococcal disease has historically been limited. An analysis of surveillance data from 1988 to 1993 from the 8-county Atlanta metropolitan area found that HIV-infected adults had a nearly 24-fold increased risk for meningococcal disease. More recently, a study from Durham, South Africa, reported that the incidence of meningococcal disease in HIV-infected persons was 11 times greater than that among HIV-uninfected persons, and HIV-infected cases had a higher case fatality ratio. A chart review of HIV-infected meningococcal disease cases reported through the Active Bacterial Core Surveillance System, or ABCs, has recently been completed. Incidence calculations from this analysis are limited to cases that meet the CDC/AIDS surveillance case definition because name-based HIV reporting was not available in all of the states during the study years. 32 HIV-infected meningococcal disease cases were reported in ABC's sites during 2000 to 2008. 25% were caused by Serogroup B, 39% by Serogroup C, and 29% by Serogroup Y. In the 4 years since the review was completed, an additional 9 cases of meningococcal disease have been reported in HIV-infected persons in ABCs. HIV-related clinical data were collected from meningococcal cases with HIV infection as part of the expanded chart review. In general, patients presented with a wide range of CD4 counts, and several had a history of an AIDS-defining condition or met the CDC AIDS surveillance case definition. The majority were also reported to be currently taking heart at the time of meningococcal disease presentation. 17 of the 32 cases met the CDC AIDS surveillance case definition and were included in the incidence calculations. Meningococcal disease incidence among persons with AIDS was 3.48 per 100,000 compared to 0.28 per 100,000 among persons not meeting the CDC AIDS case definition, resulting in a rate ratio of 12.6. In New York City, meningococcal surveillance data was matched to death and HIV registries, and as part of this study, an age-matched case control analysis was also performed among HIV-infected persons, which included a subset of cases with CD4 counts and viral load measurements near the time of meningococcal disease. 40 HIV-infected cases were reported in New York City during 2000 to 2011. 33% were caused by Serogroup C and 48% by Serogroup Y. Incidence of meningococcal disease among persons infected with HIV was calculated. Incidence was 3.4 per 100,000 in HIV-infected persons compared to 0.34 per 100,000 among HIV-negative persons, for a risk ratio of 10. A higher case fatality ratio was observed among HIV-negative cases compared to HIV-positive cases. The risk of meningococcal disease decreased during the study period for both HIV-infected and HIV-uninfected persons in New York City. meningococcal disease incidence among HIV-infected persons decreased from 4.7 per 100,000 in 2000 through 2002 to 1.9 per 100,000 in 2009 through 2011. An increased incidence was also observed for both HIV-infected women and men, although the risk ratio is slightly higher for male cases compared to female cases. In the case control study among persons with HIV, patients with meningococcal disease were 5.3 times as likely to have, as age-matched control patients, to have a low CD4 count and 4.5 times more likely to have a high viral load. So to summarize the epidemiologic data, there is an increased risk or an increased incidence of meningococcal disease in HIV-infected persons, and among HIV-infected persons, a low CD4 count or high viral load increases risk. However, risk of disease is declining along with meningococcal disease incidence in the United States. Data on the case fatality ratio for HIV-infected meningococcal disease cases is mixed. I'm now going to shift gears and we'll focus on vaccine response in HIV-infected persons. In this figure, the dark bars represent seroresponse to a single dose of MenACWID or Menactra for HIV-infected adolescents. For comparison, the hash bars are seroresponse data for healthy youth from a separate study. The data for HIV-infected adolescents is based on approximately 300 adolescents included in the study, and the proportion of HIV-infected adolescents with more than a fourfold increase in RSBA titers at week 4 was 52% for serogroup C and 63% for serogroup Y. For HIV-infected adolescents who received a single dose of MenACWID, you can see here that the response was significantly lower for those with either a low CD4 count or a high viral load. This figure shows GMTs against serogroup C at 0, 4, 24, 28, and 72 weeks. The yellow bars represent a group with low CD4 counts at study entry, and despite a second dose of vaccine at 24 weeks, response remains low through 72 weeks. The blue bars represent a group with higher CD4 counts at study entry, and these subjects received one dose of MenACWID. After an initial response at 4 weeks, GMTs wane rapidly. Finally, the green bars represent a group with higher CD4 counts at study entry, and these subjects received a second dose of MenACWID. For this group, response waned quickly after both dose 1 and dose 2. This figure shows the same as the previous slide, but shows GMTs against serogroup Y. Overall, the response to serogroup Y is higher than for serogroup C, but the same pattern of rapidly waning titers is observed. The percent of subjects who still had antibodies at week 72, or approximately 1.5 years after 1 or 2 doses of MenACWID, is shown in this table for each serogroup. The primary study endpoint was the percent of subjects with RSBA titers greater than 1 to 128, and for serogroup C, titers waned to 21 to 35%, and for serogroup Y, titers waned to 63 to 71%. The proportion of subjects with RSBA titers greater than 1 to 8 is also shown for each group, and they're slightly higher than for the 1 to 128. In summary, seroresponse to MenACWID in HIV-infected adolescents is suppressed compared to healthy adolescents, and a low CD4 count or high viral load suppresses the response even further. In addition, immune response to MenACWID wanes rapidly, and although a boost response is seen to a second dose, duration of protection is still an issue. There is a modest increase in absolute risk of meningococcal disease among HIV-infected adults of about 2 to 4 cases per 100,000 persons, but the risk is declining over time. As a comparison, the incidence of pneumococcal disease in adults with AIDS was 298 cases per 100,000 in 2007. Overall, the number of preventable cases is low. Given the current incidence of both meningococcal disease and HIV infection in the U.S., the total number of meningococcal disease cases in HIV-infected persons is likely low, and the duration of protection from vaccine is short in HIV-infected persons. The meningococcal workgroup does not propose changes to the current ACIP recommendations for HIV-infected persons at this time. The rationale for the meningococcal workgroup's support of no changes to the recommendations includes persons with HIV are at lower risk compared to other recommended groups. However, the risk is lifelong and there would be a need for multiple booster doses. We do not know if persons who are vaccinated when CD4 counts are high will still be protected when CD4 counts decline. And finally, a cost-effectiveness analysis has not been done for the use of meningococcal vaccines in HIV-infected persons, but would not likely impact the working group's conclusions. Thank you.
We can open up for any questions or discussion. Dr. Harrison.
Yeah, are there any data on immunogenicity in HIV positives with MCV4 CRIM?
I do not believe there's any data on that available. There's nothing published.
Dr. Zahn.
Yeah, Matt Zahn from NACHO. I guess I'd make a couple of comments. One is that I appreciated this data regarding meningococcal disease in the MSM population. You mentioned LA County, and they had 4 cases, and I think getting ahead of this data in terms of getting a sense in all communities of how many cases occur in the MSM population is really important, because I think LA County wrestled for a while with, okay, 4 cases in a community of 10 million. Is that something or is that not something, particularly in a situation where in years past they didn't really have data to quote unquote compare that to? LA County concluded that there wasn't something, and they didn't make recommendations compared to New York City, but they got a lot of noise from the community about whether they should do something or not. And I think the other point I'd make is, as you mentioned, local counties make recommendations about vaccination. One of them is, meningococcal vaccination is considered a travel vaccination. And so multiple counties in California, I don't know how common this was around the country, but multiple counties in California made recommendations. If you are MSM and you are traveling to New York City, these are our recommendations. Now, how advisable that was or not, but no, you go to they made those recommendations. And so the point I make is, from what I'm seeing from the data in New York, it really seems like whatever was going on there seems to be subsiding. I think a lot of times we're a lot better at letting people know there is an issue as opposed to the issue is going away. And so making that clear so that local counties and providers can make recommendations, about whether any of this is necessary anymore is kind of a worthwhile thing to do. And I think that information actually is very useful for local departments.
And this data will be published in MMWR in the next couple of weeks. So.
Dr. Duchin.
Thank you. Thanks for that information. I have a similar question or a follow-up to what Matt just raised, and that is, did the work group's deliberations identify any areas that would help or lead to changes in our approach to outbreaks among communities where there are high or numbers of cases among MSM or HIV-infected persons?
No, we didn't talk about that. We are starting to talk about our outbreak guidelines in general, both for institutional settings as well as community settings. So perhaps we can come up with something there.
Dr. Reingold.
Yeah, sorry, I may have missed this, but the recommendations in New York targeting MSM who had particular risk factors, has there actually been a study looking at risk factors predicting meninge in men who have sex with men in terms of their behaviors, use of bathhouses, things like that? I'm just curious what the recommendations were based on.
There haven't been any formal studies, and I think we did try to collect some of that information through the EpiX, but I don't think we are aware of any specific behaviors for MSM that would put them at increased risk.
So, and just to clarify, so the New York City specific recommendations were based on the epidemiology investigations that they had conducted. They found that numerous of these cases had recently used some of these apps and had been visiting these bars that they were trying to target.
Dr. Harrison.
There's lots of data in the non-MSM population that behavioral risk factors are really, really important. Drinking, going to pubs and discos, kissing. So there's lots of behavioral data.
Another quick question, and I'm not sure if we have any data on this, but do we know what the rates of vaccine uptake are in these two populations for other vaccines that are commonly recommended? Hepatitis B, for example, and the suite that we recommend routinely for HIV.
Yeah, I don't think there's great data. Years ago, there was some data on pneumococcal polysaccharide vaccine and HIV-infected, and it was, in the 50s or so. But I'm not aware of the hepatitis data, for instance. I think some of those coverage surveys will group immunosuppressive groups together so that they're not identifying as HIV, but we can check and if there is, make it available.
Well,
Dr. Wren?
historically in San Francisco, it's been very difficult to get men to get all 3 doses. The fall off after a first dose has been very, very strong historically. I think the coverage of 3 doses is still quite low.
Thank you. At the microphone.
Yeah, hello, I'm Dr. Zucker with the New York City Department of Health and Mental Hygiene. And thanks for the good presentation of a lot of our data. And from our perspective, looking at the data and the persistent increased risk for invasive meningococcal disease in our MSM and HIV population, we are currently struggling with what to do about our recommendations going forward. And in fact, if anything, we're leaning toward the need for a routine recommendation for meningococcal vaccine in this group. And I think we've had internal deliberations as well as we're meeting with our partners. And we think it's really quite important. We have a large population that would fit into this, in terms of that would have an indication for a vaccine. And I guess from the department's perspective, we're, somewhat disappointed that there's not a more formal sort of review and grade and sort of deliberation by the full work group for whether or not there should be a recommendation. And I guess we've struggled with whether or not we should be out in front, of ACIP on this recommendation or not. So, we appreciate, all the results and the sort of conclusions, but we do request that there actually be a more sort of formal, grade and consideration of the recommendation. Thank you.
Yes, Dr. Bennett.
Just one quick question. Do we know about the vaccination status of these cases? Because many of them might have been young enough to have received previous meningococcal vaccine.
Most of them, it was unknown. I looked at the line list. There were a couple that were, but not very many that we knew.
Any other discussion? And seeing none, I guess we move along to the next topic, Dr. Patel, and talking on the use of Serogroup B meningococcal vaccine during outbreaks on college campuses.
Good afternoon. I will be presenting on outbreaks of Serogroup B meningococcal disease on university campuses. Oh, okay. So the incidence of meningococcal disease in the U.S. has been steadily decreasing and reached an all-time low in 2013 with a provisional count of 519 cases among all serogroups. Serogroups B, C, and Y cause the majority of disease, with each serogroup contributing to about a third of cases. Although outbreaks of meningococcal disease are typically caused by serogroup C, recently we have been also seeing serogroup B outbreaks, particularly on college campuses. Meningococcal disease rates peak in less than 1-year-olds and again in adolescents and young adults between the ages of 16 to 21 years. The peak in adolescence occurs similarly for all serogroups and possibly reflects the frequency of exposure to people from whom one can acquire carriage. With the recommendation of conjugate MenACWI vaccines for adolescents in 2005, serogroup B, shown by the purple line, now accounts for the highest incidence of disease in this age group. Over the past 5 years, 5 serogroup B outbreaks on college campuses have been reported to CDC. Universities 1 and 2 both had small clusters in which cases occurred within a relatively short time of each other. The epidemiology at University 3 differed in that the outbreak spanned over 2 academic years. Now, with the availability of a MenB vaccine in 2013, we had a potentially different approach to control the outbreaks at Princeton University and University of California, Santa Barbara. 8 cases of MenB were reported among Princeton University students or persons with links to Princeton University from March through November 2013. The attack rate was 134 per 100,000 among undergraduates, over 1,400 times higher than the background incidence rate for 17 to 22-year-olds in the US. There have been no fatalities, but 2 cases with sequela, including one with the neurocognitive deficit and one with partial hearing loss. Although laboratory testing demonstrated that all the strains isolated from the cases were identical by sequence type, PFGE patterns, and molecular antigen typing, there was no direct epidemiologic link between cases. Cases were reported in all 4 class years among students living in dorms and occurred 2 to 4 weeks apart during the academic year over an 8-month period. With this evidence of sustained transmission and large population at risk in which the majority of students reside on campus, Princeton University, the New Jersey Department of Health, and CDC decided to implement a vaccination campaign to prevent additional cases. Although there is no currently licensed MenB vaccine in the US, Pfizer has a MenB vaccine currently in development. Novartis, the manufacturer of Bexsero, or MenB, had its vaccine recently licensed in Europe, Australia, and Canada. Effectiveness was inferred based on immunogenicity of a 2-dose series, with an immune response seen after 1 dose. Safety data in almost 1,600 adolescents showed greater than 10% reported non-serious adverse events. However, no serious adverse events were reported. MenB contains 4 antigenic components. The isolates from Princeton expressed 2 of the 4 antigens, FHBP and NHBA, in sufficient quantities to suggest protection with MenB. Additional testing demonstrated that isolates from 4 of the cases was killed by pooled post-immunization sera. So based on recent licensure of MenB elsewhere, a good safety profile, and the concern for occurrence of additional cases upon commencement of the new academic year at Princeton University, CDC and FDA began to explore the use of MenB in outbreak settings under an expanded access investigational new drug protocol in August. Expanded access INDs provide investigational products for serious or life-threatening conditions when there are no otherwise adequate approved alternatives. Expanded access INDs are not intended for product development or clinical trials. As part of the IND submission process, Novartis performed testing of isolates between September and November to determine vaccine antigen matching. CDC and the New Jersey Department of Health conducted an epidemiologic investigation at Princeton in October to identify the target population. The IND was officially submitted in November and included a safety monitoring plan, consents, vaccine information sheets, and data collection instruments. Approval by both FDA and CDC IRB shortly followed. Additionally, negotiations and contractual agreements between the various stakeholders were finalized in early December. The recommended population for vaccination included all undergraduate students, graduate students living in dorms, other persons with medical conditions putting them at increased risk for meningococcal disease, or spouses or parents living with undergraduates in dorms. The number of people in the total target population was 5,772. To date, there have been 3 vaccination clinics. The first dose clinic was held over a 4-day period in December. The second dose clinic was held last week. Over 75 people from Princeton University, Maxim Healthcare, and CDC were on site during these clinics. High coverage was seen for both doses, with 95% of the target population receiving the first dose and 88% of first dose recipients receiving the second dose. An additional catch-up clinic is planned for March. Mandatory reporting of all serious adverse events is required to FDA and includes death, a life-threatening adverse event, hospitalization, substantial disruption in the ability to conduct normal life functions, or a congenital anomaly or birth defect. To date, the rate of SAEs reported is 2.0 per 1,000 vaccinees following the first dose and 0.2 per 1,000 vaccinees following the second dose. No SAEs have been determined to be causally related to MenB. Additionally, there have been no concerning patterns among other types of AEs reported to date. In November 2013, 4 cases of MenB with no direct epidemiologic links occurred among undergraduate students at University of California, Santa Barbara. All 4 recovered, with complications in 1 case patient resulting in bilateral foot amputation. During the epidemiologic investigation, an additional case associated with UCSB, shown in green, was identified in March 2013. This suggested there was sustained transmission of MenB occurring at the university and that vaccination would be an appropriate strategy to control the outbreak. The attack rate was 21.1 per 100,000, which is 234-fold higher than the background incidence rate for 17 to 22-year-olds in the US. Isolates from the 4 cases were sequence type 32 with identical antigens. There were 2 different PFGE patterns, which was thought to be due to horizontal gene transfer between the circulating strains and thus still considered to be the same outbreak strain. Although this strain was different from the Princeton strain, additional testing of isolates from 3 of the cases demonstrated killing using pooled MenB post-immunization sera. Due to the concern that additional cases would occur, a CDC-sponsored expanded access IND was approved by the FDA for use in the UCSB outbreak. The target population was similar to Princeton University and included all undergraduates, graduate students, or faculty living in dorms, and others with high-risk medical conditions for meningococcal disease. The estimated target population is approximately 20,000 people. The first dose campaign started on Monday, February 24th, and will continue until March 7th. A second dose clinic is planned for April, and a safety surveillance plan is in place in collaboration with UCSB and CDC. Although the primary objective for implementing a vaccination strategy is to prevent additional cases, there are a number of challenges associated with using an unlicensed vaccine to control outbreaks. The IND preparation process is unique for each setting and needs to address the specific epidemiologic and laboratory findings for each outbreak. There are also specific safety monitoring requirements that need to be followed when using an unlicensed product under an expanded access IND. There are also additionally, the logistics of vaccine procurement and implementation requires participation from multiple stakeholders in order to conduct a campaign in a timely and effective manner. Despite these challenges, both Princeton University and UCSB demonstrated extraordinary efforts in rapidly standing up these campaigns. Although we do not expect an increase in MenB outbreaks on college campuses, CDC has recently formed a meningococcal outbreak work group comprised of ACIP meningococcal work group members, ACIP members, state public health officials, college health professionals, representatives from university administration and the insurance industry, and CDC to address potential issues related to management of these outbreaks. The objectives are to review available data on the recent epidemiology of meningococcal disease and outbreaks, consider options for updating the current meningococcal disease outbreak guidelines, and develop guidance for use of meningococcal vaccines, both licensed and unlicensed, in an outbreak setting. In summary, vaccination is now possible in response to MenB outbreaks. Implementation of an unlicensed vaccine requires coordinated efforts between the institution, state and local health departments, the manufacturer, FDA, and CDC. An ACIP outbreak work group is currently developing guidance for management of MenB outbreaks, and this interim guidance will be presented during the June ACIP. I'd like to thank the numerous stakeholders, particularly FDA, that have been involved in implementing this expanded access IND to control 2 recent outbreaks of MenB on college campuses. Thank you. Happy to take questions.
Thank you very much. We'll open it up for any questions or comments. Cindy. Sorry.
Just a quick question. In each of these cases, which of the entities was responsible for drawing up and submitting to FDA the IND?
So it's a CDC-sponsored IND. So CDC is actually the principal investigator, and then each site has their own specific site investigators.
Dr. Zahn?
Yeah, thank you for the presentation. So for Santa Barbara, it sounds like that one case that happened in March, an awful lot kind of hangs on that event. How common or uncommon is this strain, this specific strain of meningitis? Because if it's a common type, you could argue that that's a random event that kind of happens randomly and isn't necessarily attached to everything else. So.
Right, so ST32 is common. It's the second most common MenB strain that we see in the US. I think the key was that the strain was similar to the outbreak cases. The PFGE patterns were similar. And you know, the other issue is you just don't know which way it's gonna go. And so that's one of the biggest issues. And so now in the setting of having a vaccine potentially available, all the stakeholders were interested in pursuing that route.
Yeah, Dr. Warshawski may want to comment on this, but I believe in Canada now, MenB is the major serogroup that causes disease in all people, not only infants. So, Tom or Amanda, or if you want to answer, was there any history of travel to Canada in the Princeton group, particularly in the early cases?
For Princeton specifically, there's one traveler to Greece. None of the other ones traveled outside of the country. I don't know for UCSB, no travel.
Go ahead.
Thanks. So just a comment. Serogroup B is our most common serogroup, but largely because we've controlled Serogroup C. It's still a very rare disease in Canada. And as was mentioned, we do have the Bexsero vaccine recently authorized for use, and the National Advisory Committee is just about to deliver its recommendations in the next few weeks, months.
Thank you. Dr. Harrison?
I'm just curious, how did you determine that the PFG variability was due to horizontal gene transfer as opposed to SNPs in the restriction sites?
It was a complicated discussion with the laboratories involved. I'm going to punt this to Amanda or Tom that were maybe involved.
So that was the hypothesis. I think there's actually additional genetic analysis happening as we speak, looking at SNP variation and sequencing the isolates. The preliminary suggestion is that the isolate from March may be a progenitor for both of these two strains, but there's lots more work to be done.
The PFGE patterns were dramatically different, and so different on multiple bands, I think 6 bands or something. So it seemed like some large event rather than small ones, but that's just a hypothesis.
Dr. Plotkin?
Yeah, I'm surprised not to hear any carriage studies. I think it would be extremely interesting to know whether the MenB vaccine has any effect on carriage, and indeed to know how widespread the organism was at Princeton or UC Santa Barbara. And related comment is that it would be interesting to know what the carriage rate is of Group C in MSM and the relating to the previous discussion. And I would just point out that the advantage of the conjugate vaccine is to affect carriage, so that there might be some argument for using the conjugate vaccine in populations with widespread carriage, regardless of the rate of active disease, so as to terminate an outbreak more quickly.
If I can follow up on that point too, as someone that does a lot of nasal swabs for influenza, coupling a vaccine clinic where you have 97% attendance with a nasal swab would provide an incredibly rich set of data for looking at things like carriage. I think Dr. Dushan.
Thank you. Quick question about the visitor to Princeton University, the visitor to campus, if you can say anything about that case. And was it a non-student, or are there anything remarkable that would explain why that person would become part of the outbreak?
So this was a student that was visiting campus as part of, I believe, an athletic recruitment. And so unlike, Princeton has for instance, in April, they have something called Princeton Preview, where students come in and spend a day or a night with the Princeton students. This was a little bit different. This student actually engaged in social behaviors and activities similar to other Princeton students, and then sort of, not just Princeton students, but college students in general. And developed disease fairly shortly after that.
So in follow-up to the question, the earlier presentation, is there any consideration to changing the surveillance form of the recommendations or working with CST on the national surveillance for meningococcal disease to include HIV status and or sexual preference?
Amanda?
I can answer that. Those are all things that we're thinking about and considering. Changes to national reporting forms are actually complicated and can take a long time to do, but we are considering recommendations for what state and local health departments can collect data on their own. How they report that may be challenging.
Dr. Herman?
Yeah, and of course, state health departments some have already made this decision, like California. We're now collecting this information routinely and trying to go back in time to get it for as many as we can. However, as you may know, this is not something that always comes up or is discussed necessarily, so getting that asked regularly might be an issue, but we're trying.
Dr. Clark.
Sure, just to expand maybe on Dr. Duchin's question, I think the prospective student, I've called them, was sort of the exception that proves the rule, in that they were resident in the dorms for just a couple of days. So the risk is not zero to visitors, but it's quite low. And one concern we heard about was the risk of ongoing transmission when kids come home, or will the outbreak spread? And that there's no indication that happened. So there were no secondary cases. The other question is, certainly we thought about carriage studies, and some, I expect Dr. Dole will comment on what's known about the impact of this vaccine on carriage. We discussed and are still thinking through potential carriage surveys after vaccination, but in this case, you have to have IRB approvals in place, and the urgent goal was to get the vaccination program up and running first.
At the microphone.
Yeah, Peter Dull with Novartis. I just want to, again, thank CDC and the organizations that brought this to happen. I think it was a great example of a collaboration, with FDA, with the companies, with the recommending bodies, with the various state and health departments. But I just do want to caution that this idea of this as a sustainable solution for outbreaks of MenB is something I just want to step back and pause, because this you look at the timelines that Dr. Patel laid out as how long it took to walk through the steps. Yes, there's work with the FDA approving the IND. Yes, there's setup of the implementation of the campaign, but also on the company side, we are not in surge capacity that you pick up the phone, we can label, ship unlicensed vaccine, somewhere in the U.S. very quickly. So these outbreaks clearly happen fast. I think we do have to have a more sustained solution for this. We are actively talking with FDA about how we can get this vaccine licensed in the U.S. as well. And just a quick pause on the carriage. Yes, we have done carriage studies. We have done a large carriage study in the UK, approximately 3,000 subjects enrolled. We showed some data at a previous conference in the UK, probably last fall, and does show that there is some effect on MenB carriage with the Bexsero vaccine. So really, you're going to need to see that in a broader implementation to see a true impact on a herd effect, but there are some early look at an impact on herd immunity with this vaccine. So.
Any other question or comment? Hearing none, I think it's. We want to do these. Okay. Yeah, actually, I think we're going to take this advantage of kind of this pause between meningococcal and pneumococcal, and we have if they're available now, I'm not sure if they're here or not, but a couple people speaking. in terms of pneumococcal vaccine and pneumococcal meningitis. So I'm wondering if Robin Kephart is.
Dr. Pickering, they're on their way in now, but if I could go ahead and speak to meningococcal real quick. She's on her way in the building right now.
Okay, go ahead.
I just want to say thank you to all the work that this body did, to make sure that these kids were protected and you stopped this outbreak at these 2 universities. I also want to say that I think moving forward, and my opinion, and $5 will get a cup of coffee most places, okay? So, and I know my opinion compared to the people that sit here at this table every day and work hard to make sure that we're all protected is nothing in comparison. But I would really encourage this committee moving forward that we make sure that we don't pick and choose groups that should be vaccinated against other groups that should be vaccinated. I think moving forward, as we do have new and better vaccines, more vaccines to cover meningococcal disease, especially in infants, we need to move forward with recommendations to protect infants all the way through that recommended ACIP group plus MSMs and anybody else who might be at risk. I also believe that we risk too many lives when we wait for an outbreak somewhere. We've seen it in Oologah Elementary School. We've seen it recently in Princeton and California. We need to be proactive. Public health is the best thing, the best money that we can spend in this country. And I firmly believe that if we put our money into public health, vaccinations, public health, that our health care bills are going to go down. And health care overall will go down the cost. It's the best money we can spend. Again, thank you for allowing us to have a say in these committee hearings. And Robin and them, they have a little boy in a wheelchair, so they're on their way in.
I'm just wondering, out of fairness, so they don't have to rush in here and speak, if we take our lunch break
right
and
after
have them
that's
lead
perfect.
off, if that's okay. So we'll have both Robin Kephart and Trish Parnell speak to us immediately before the start of the pneumococcal session.
Thank you.
Thank you.